Hi, this is Dr. David Kahn, the Medical Director of Bright Heart Health Addiction Treatment Unit, and today I'm going to give you an overview of opioid addiction and pharmacological treatments for opioid addiction. First, you should know a little bit about the history of opioids. Opioids were derived from the opium poppy. Here you see an opium poppy that has blossomed, and this is the seed pod. And farmers scrape the edges, and the brown material that seeps out of it is literally opium. It's typically a combination of morphine as well as codeine. These are naturally occurring opiates. Opioids have had a long history in American medicine, both patent medications and prescription medications. In the middle, you see Miss Winslow's soothing syrup, which contains morphine. On the bottom left, cough. The problem has been solved by glycoheroin. Yes, heroin. Most people don't know this, but heroin was originally synthesized by the Bayer company. Think Bayer aspirin. And the heroin turns out is a very powerful opioid that was meant to treat morphinism. They had concerns that people were getting addicted to morphine and they thought heroin was safer. And lo and behold, it did work. Now, some of us wonder why are so many opioids available in the late 1800s, early 1900s? Well, the answer is that there are conditions that we think of as not particularly problematic. For example, cough in children with croup. Well, in the 1800s, that could potentially be fatal, and opioids are the treatment of choice. If you think about sanitation, we don't worry about our drinking water, but historically, drinking water could give you severe diarrhea, which could then result in death from dehydration. And opioids were definitively the answer to that problem. So a lot of opioids were around. Some people declared themselves addicted by overusing and losing control, using it compulsively, having cravings and consequences. And some people are probably self-medicating conditions, certainly before opiates became prescription-based. This is an opium smoker. Opium is the product that comes straight from the poppy seed after harvesting. And people will typically smoke opium. Opium itself is a relatively low potency opioid. This is opium use in San Francisco. I find this cute because I don't know of any cats that are that willing to cuddle, but if you look at the description, the cat has become addicted to the fumes of the drug. Here's some pictures of opioids. On the upper left-hand corner, you see an opium poppy that's open. It won't be harvested until the leaves fall off or the petals fall off of the poppy. On the bottom left is black tar heroin, although I'd say it's a fairly refined version because most of the black tar heroin in San Francisco, or at least on the West Coast, looks like black tar, literally like road tar. On the bottom middle is China white. This is the more highly refined heroin, but it's coincidentally what we're finding is more and more highly refined heroin is actually cut with medications like fentanyl. Fentanyl is a very high potency opioid, very highly addicting. And also the bad thing about fentanyl is it's much more likely to produce a fatal overdose rapidly. And in the upper right-hand side, you see somebody injecting drugs. And on the right is somebody's rig, which usually involves a needle, a cooker such as a spoon, as well as a tourniquet to find a vein. It's important to realize that opioids themselves carry risks, but also the needles and the paraphernalia used to consume opioids carry great risks. And that's why it's important to talk to your patients about access to clean needles. In California, we have legislation which people can purchase needles without a prescription. What we see with the overdose deaths is natural and semi-synthetic opioid analgesics are increasing. This number continues to increase. This is an older slide. Methadone overdose deaths are overrepresented, and that has a lot to do with the pharmacology of methadone, which I'll get into later. There are synthetic opioid analgesics, excluding methadone. What we see over the last several years is that natural and semi-synthetic opioid analgesics, that we're seeing an increasing rate of overdose deaths. In 2015, the rate of overdose deaths from opioids exceeded that of car accidents as a cause of death, as well as gunshot wounds in 2016. Methadone is surprisingly overrepresented given the relatively low prescription rates of methadone. The majority of the methadone that they find in accidental overdoses are pill form methadone, which is different from liquid methadone that clinics dispense. There's synthetic opioid analgesics that exclude methadone, things like fentanyl that I previously mentioned, that are on the rise. And if we were to plot this graph out, I would say that number would significantly increase in the last 2 years. This is a fascinating study. In this study, they followed the 40-year natural history of heroin addiction. This is a UCLA study where they recruited 581 heroin addicted individuals. And they actually followed 88% of them over 40 years. So that's a remarkable study unto itself. A couple of things that I'll point out about this slide is that heroin addiction is a near fatal illness. 50% of the sample were dead that they knew of at the end of 40 years. And this is a young patient population. Average age is around 25. 22% achieved abstinence, but they didn't ask questions about other opioid use, nor did they ask questions about alcohol use. So I'm dubious that the abstinence is just pure abstinence from all opioids. They just didn't measure it in the study. The other thing I'll point out is methadone maintenance, which has been a strongly evidence-based treatment for a long time, never gets great uptake. There's barriers in methadone, and I think that's part of the reason, such as being the needed compliance with the clinic. Here's some commonly abused opioids and street prices. Diacetylmorphine, heroin, it costs anywhere from $5 to $15 for an eighth of an ounce plus an adulterant. The adulterant is oftentimes something that looks, smells, and tastes like heroin, but increasingly, especially places outside of the West Coast, we're seeing fentanyl and carfentanil as adulterants in heroin. Hydromorphone, meperidine, hydrocodone, oxycodone, these are pills that are typically prescribed, although there are injectable forms of hydromorphone and Demerol as well. Morphine is known as MS-Contin or Amorph. That is the base for heroin. Fentanyl, like I said, is contaminating more and more heroin nowadays, and it's a highly lethal medication, even in very small doses. And then there's methadone. The majority of methadone that's prescribed at a methadone clinics doesn't get diverted. There's close controls on the methadone versus the methadone prescribed for the purposes of pain. That's typically the stuff that they find when they seize drugs for sale that are not being used for their intended purposes. There's various street names. You can read these, but when it comes to street terminology, there's many terms for it. When it comes to street terminology, I would say, ask the patients, what is this stuff called? This is where I figured out most of this information from. It's my patients that I've worked with over the years. You need a little primer on heroin 101. There's new production in South America, and it's not particularly new. It's been going on for about 15 years now, 15, 20 years. What we see is a high purity and potency product, which then becomes smokable. When you can smoke a drug, it has a lot less stigma than injecting it with the needle. Historically, heroin has been very low potency and purity in the neighborhood of 1% to 2% pure by weight. Now it's going up to 15, 20, even higher percentages depending upon the geographic location. Detoxification is of limited long-term efficacy, and I can't stress that enough. Getting people off of the drug is just the start of treatment. It's good for a lot of things, but long-term abstinence is not one of them. Detoxification, that is. And the most effective treatment for chronic users is methadone maintenance or buprenorphine maintenance. There's different medications that are available. Methadone, LAM, these are opioid agonist therapies, OATs. Buprenorphine is also an opioid agonist, but it's a partial agonist, which I'll get into later. And then there's naltrexone, which is available in pill and injection form, which produces opioid blockade, meaning that if somebody uses opioids, it's not going to have an effect. When I think of opioids, I think of the naturally occurring opioids. This is what's harvested out of the poppy. You have opium, tincture of opium, and camphorated tincture of opium, which is paregoric. There's semi-synthetic, which starts with the natural precursor, such as opium, and then they chemically change it to be a semi-synthetic medication. These will include hydromorphone, oxycodone, and diacetylmorphine, which is heroin. Then there's the frank synthetics, which are not produced at all have no natural precursor. It's important to distinguish the synthetics from the other ones because synthetics don't always reliably show up on opioid drug screens. For some reason, meperidine, Demerol does show up regularly, but methadone tests completely differently. And buprenorphine, which is a synthetic itself, is a medication that tests separately from the opioid drug screen. So if somebody's on methadone or buprenorphine, I would not expect an opioid positive test. They really should test differently because they're synthetic medications. When somebody withdraws from opioids, think of it as a bad case of the flu. Grade 0, you see drug craving and anxiety and drug-seeking behavior. Grade 1 withdrawal, and this is based upon heroin, people start to get flu-type symptoms. From 12 to 36 hours, grade 1 withdrawal, you see yawning, perspiration, tearing of the eyes, sniffling. They can't sleep, which is often the first symptom that people report when their dose is insufficient of an opioid agonist therapy, such as methadone or buprenorphine. In grade 2, that's within 12 to 36 hours of last using. You see dilated pupils, goose flesh, that's where the term cold turkey comes from, so they get piloerection. You get muscle twitches, typically affects the legs, lower back, and hot and cold flashes. You can see chills, aching bones and muscles. And we also see a decreased appetite, irritability, and sometimes people can have a resting tremor. 48 to 72 hours after their last opioid use, he gets rather severe withdrawal, or last heroin use. Diarrhea, vomiting, nausea, and weakness. You can see an increased blood pressure. People can't sleep, and you may see a low-grade fever of typically less than 100 degrees. Now, this is all based on heroin, which is a very short-acting opioid. If your patient is using other opioids, such as methadone, which are long-acting, these symptoms may not show up at the predictable times and may come on later. They also may not be as severe as short-acting, high-potency opioids like heroin. If you think about opioid withdrawal severity, this is a graphic that was done by Costin and O'Connor. And this isn't meant to be a perfect representation. But if you look at heroin, it's a fairly severe withdrawal syndrome that doesn't last very long. Methadone is not nearly as severe, but it's much longer. And I would argue that that goes out to 30 to 45 days for some patients. Buprenorphine is a much less severe withdrawal syndrome than methadone or heroin, and it's longer than heroin, but shorter than methadone. But also, I would say that it goes out for some period of time, up to several weeks, 2 to 3 weeks, for the agonal symptoms to resolve. Those agonal symptoms I call the wired tires, meaning that the patient is wired, they're anxious, they're irritable, and they can't sleep despite being quite fatigued. So as far as relative opioid withdrawal severity, feel free to share this with their patients so they can understand it. Another thing I'll point out is it's not the y-axis that's important. It's not the absolute severity of withdrawal. It's the x-axis. How long does it take for the withdrawal to get better? Because if you think of the struggle of a patient, they know that a single dose of opioid will help them to feel better. So it's the length of the withdrawal that typically torments patients much more than the absolute severity. You can measure opioid withdrawal with the clinical opioid withdrawal scale. There's a subjective opioid withdrawal scale, and there's many different types of withdrawal scales. The COWS is nice because it's highly detailed, but at the same time, typically we use it in more research settings, although we do that as part of our initial assessment at Bright Heart Health. So when I think of opioid addiction medications, first I think of medications for detoxification. This is for a patient who wants to stop using their other opioid. We can substitute with another opioid such as methadone. It's illegal to do this on an ongoing outpatient basis. You can prescribe for up to 72 hours for detoxification, but for an ongoing basis, it's illegal to do unless you're in a specialized opioid treatment program. Buprenorphine, which is a partial agonist, requires the DEA X number. And then there's non-opioid symptom relief, with medications like Clonidine or lofexidine, which are alpha-2 adrenergic agonists. There's antispasmodic and antidiarrheal medications, nonsteroidals for bone pain, as well as medications for sleep. When dosed adequately, Clonidine can suppress 90% of opioid withdrawal symptoms, but typically you need very high doses of Clonidine, which frankly scare physicians, but it also scares the patients too. But you also need the antispasmodic medications, nonsteroidals for bone pain, as well as something to help with sleep, such as the diphenhydramine product. For maintenance, the idea of maintenance is that stopping drugs is easy. Staying that way is the hard part. There are medication options that are opioid-free, such as naltrexone, which is given either an oral or 30-day injection. I'll go on later to tell you that this is, generally speaking, an overall poor idea. People don't stick in treatment, and nor do they stick with the medication. There's opioid agonist medications, which include methadone, buprenorphine, and LAM, levo-alpha-acetylmethadol. LAM turned out to be a great medication, but it's been taken off of the market because of warnings around QTc interval prolongation on EKGs with the potential for fatal arrhythmias. Naltrexone, the opioid blocker, we have to think about it in terms of efficacy versus effectiveness. It has very high efficacy. It's an almost perfect long-acting blocker of opiates. However, if we look at the actual research, it's got limited effectiveness. It's most effective in people with monitored treatment, professionals, executives, people on probation. And there's poor compliance in a heroin-using population and poor treatment retention. And this is a term you'll hear over and over again, treatment retention. We want to keep people in treatment, and we want to keep people in treatment for as long as possible. And if a treatment doesn't retain people in treatment, generally speaking, it's not a good idea. There's combined strategies for naltrexone which are helpful, which include contingency management and family therapy. And there's also criminal justice leverage, which seems to help as well. There's this ultra-rapid opioid detoxification. It's usually done under light to heavy anesthesia, and people are administered an opioid antagonist, such as naloxone or naltrexone. It's an expensive treatment, but there are few long-term clinical trials, and none have demonstrated improved overall results. The risk is extremely high because people lose their tolerance to opioids, and the risk of overdose death is greatly increased when somebody goes through an ultra-rapid opioid detoxification. And that's true of all detoxification regimens, whether it's methadone, buprenorphine, or Clonidine. Clonidine is an alpha-2 adrenergic agonist, and it suppresses activity in the locus ceruleus. The locus ceruleus turns out to be the root of many of our opioid withdrawal symptoms. Essentially, when somebody becomes dependent upon opioids and they're withdrawn, you see this massive outflow of the locus ceruleus of noradrenergic neurotransmitters. This is where the blood pressure goes up. This is where people sweat. This is where people are in a fight or flight response at all times. Clonidine decreases most withdrawal symptoms, but the disadvantages is it requires dose titration. There's orthostasis. People get dizzy when they stand up, and it doesn't treat the insomnia, muscle pain, or craving. The protocol that we typically use is 0.1 to 0.2 milligrams every 4 hours, which is a very high dose for somebody for the treatment of hypertension. And we go up to 1.2 milligrams for 24 hours for 10 to 14 days. So it's a very high dose, but it does suppress the majority of opioid withdrawal symptoms. Now, maintenance. Methadone was based upon Vincent Dole and Marie Neiswander's opioid deficiency theory. And it's a theory that I subscribe to. If you think about somebody who is dependent and frankly addicted to opioids, the neurobiology says that the number of opioid receptors in their brain blossoms like mushrooms after the rain. And the consequence of this is that people need more opioids in order to feel normal. Methadone as a medication was found because it's a very long-acting medication. Typically, a blocking dose of methadone is more than 60, if not 80 milligrams per day. And by blocking dose, it means that their opioid receptors are saturated and other opioids can't take effect. LAM was a very good medication, but unfortunately, it's off the market at this point. And then there's buprenorphine, which is formulated with or without naloxone. Naloxone is the opioid blocker, which prevents people from injecting the medication. Buprenorphine is a partial agonist, and a partial agonist means that it has high opiate receptor avidity, but low innate activity, meaning that it attaches the receptor very tightly, but doesn't turn it on all the way. The dose is anywhere from 2 to 32 milligrams a day. And one piece that I'll say to you is that every person has a different dose. There's individual variances in metabolism, brain chemistry, and the dose that they need can hardly be predetermined. You have to do it based upon clinical assessment. And typically the symptoms that they report, an ideal dose of buprenorphine will keep people comfortable for 24, if not 48 hours. And by comfortable, meaning that they can feel like they can get on with their lives. They're not suffering from cravings. They can sleep normally and they can participate in life. And that's what I consider to be an adequate dose. The absolute dose itself is actually far less important. We've heard 12 or 16 milligrams of sublingual buprenorphine is the dose, but I have many patients on 32, sometimes even, and a few on even higher doses of buprenorphine. And that's simply what it takes to suppress withdrawal, cravings, and help them to feel normal, which is the goal of treatment. If we use methadone for withdrawal, we're substituting a long-acting opioid for a short-acting opioid, such as heroin. Typically, the doses, and again, this is done in an opioid treatment program, is 20 to 30 milligrams for 2 to 3 days, and then they taper by 10 to 15% per day. This is a very effective treatment for affecting detoxification, but it's low effectiveness for the treatment of the disease as a whole. There's very poor longer outcome results from either 21 or 180-day detoxification protocols. All of the studies suggest that once people drop below 30 milligrams a day, typically people are dropping out of treatment. A little bit about methadone maintenance. Methadone is a highly effective treatment. If we look at the impact of methadone on intravenous or injection drug use, I'm sorry, that's an old slide, and you should really call it injection drug use because not everybody can hit a vein if they've been injecting drugs for a long time. But what we see is when people come in, a certain percentage are injecting drugs, but it takes some time for people to stop injecting drugs. Having said that, the benefits from methadone are realized fairly quickly in reduction of risky behaviors such as criminal activity, sharing needles, and all the other stuff that's necessary to maintain a heroin habit. If we look at dose responsiveness curves, it turns out a little methadone goes a very long way. I'll point out there's two significant shoulders here, from 10 to 30 milligrams, and then at the 60 to 80 milligram range. If we look at the dose of methadone, sometimes people typically need higher doses in order to get away from heroin. If we look at the impact of methadone on crime, and this is not including heroin use itself, this is petty theft, grand theft, all those types of things. What we see is that we see a massive decrease in crime in patients who were involved in methadone. And I'll tell you that that data is also true for buprenorphine as well. Now, this is the most stunning slide to me. Essentially, when we look at the relapsed injection drug use after methadone, this curve is completely linear. For you physicians who work in different settings, we're used to different die-off curves. Sometimes they drop sharply down. Sometimes there's a decline over time, but this curve is nearly linear. It goes almost straight up, and that to me is stunning. I'll propose to you that in my clinical experience of treating over 1,000 heroin addicted patients, or opioid addicted patients for that matter, this number continues to go up in excess of 90%, but it's completely linear. So somebody stops maintenance treatment, they tend to relapse. If we look at death rates in people who are treated and untreated, people in methadone and who voluntarily leave methadone have much lower death rates. If they're kicked out of methadone or they're untreated, we're talking about death rates of about 7% per year. I'll propose to you that there are very few disease conditions in which people die at that higher rate. And so again, opioid addiction is a deadly disease. And again, this is the natural history of heroin addiction that underscores this point that many people die as a result of their addiction. Also note that 12% of the patients were lost to retention. Presumably a good percentage of the patients also died as well. So methadone maintenance outcomes. It's the kind of the historical standard for opioid treatment. It's one of the most overproven treatments in psychiatry and drug abuse literature, and detoxification methods succeed a very small percentage of the time. We see a reduction in death rates, drug use, criminality, and HIV spread. We also see an increase in employment, social stability, retention, medication compliance, as well as monitoring. Methadone as a medication prevents withdrawal for anywhere from 24 to 36 hours and acts by competitive blockade. Essentially, you have so many opioids around that it blocks the euphoria associated with heroin. It's medically safe. We have 10 to 18-year studies supporting medical safety, and its use it can be used in pregnant patients who suffer from addiction to opioids. The pharmacology of methadone is that it's a mu agonist, and I'll get into the pharmacology a little bit later in the slides. Once you take the medication orally, the majority is available. If we think about methadone for analgesia, for pain, a single dose is about similar to morphine. You get 6 to 8 hours of pain relief. However, there's an accumulation of methadone. So people who are non-tolerant with repeated use for pain can become sedated and experience respiratory depression. I haven't said this before, but respiratory depression is the reason that opioids kill people. It literally stops their breathing. And so the risk with methadone, when it's not managed carefully, such as in an OTP, is that people try to take it like they were taking it for morphine for pain. And it does work, but the problem is that then it gets absorbed. But for every dose change in methadone, typically takes 3 to 4 days before it settles. And so somebody can achieve analgesia, pain relief, but still be at risk for overdose because their methadone blood levels are continuing to rise. Most methadone is absorbed within 30 minutes after the initial dose, and you see peak plasma levels in 2 to 4 hours after methadone's been taken. Methadone has a reservoir effect. It's heavily protein bound. It's also stored in the liver and later released into circulation. And it's lipophilic, meaning that if it's injected, it readily crosses the blood-brain barrier and can produce a high. That's why most methadone that's out there has a significant amount of glucose or some other additive in there to discourage injection. It really hurts to inject liquid methadone. It's metabolized by the liver. You get N-demethylation and cyclization, and you get the byproducts of EDDP and EMDP. And the metabolites are inactive. And typically you get the metabolites excreted unchanged, and unchanged methadone that comes out in the bile as well as the urine. There's some methadone, some patients on methadone who are rapid metabolizers. That sort of yellow-orange zone is the ideal therapeutic range. And a rapid metabolizer, once they take the dose, they get a spike in their peak level, and at the trough level, they are subtherapeutic. And the recommendation is for divided dosing. This is a clinical assessment, which I can certainly be happy to talk to you more about later. The initial dose is usually not greater than 30 milligrams. Again, this is in the setting of an opioid treatment program. It's really key to identify people with low dependence. These are people who use weak opioids such as hydrocodone, codeine, or opium. If people are non-daily users, they could have a low tolerance. If they don't inject drugs, they could also have low tolerance. But you're allowed to give up to 40 milligrams in the first day of treatment. Typically takes 3 to 4 days to stabilize in the serum, their blood levels. So the rule is start low and go slow. Patients are inherently uncomfortable the first couple of days, but we do this as a matter of safety. In fact, during the periods of methadone induction, mortality rates jump by up to 7 times compared to just injecting drugs themselves. If we look at serum methadone levels, which goes to the fact of whether somebody's a rapid metabolizer or not, we want to see the trough typically above 200 nanograms per milliliter and the peak less than 800, although your clinical assessment will always trump the blood levels. How is the patient doing? Because that's what really matters. There's significant medication interactions with methadone. The cytochrome P450 system is what metabolizes methadone. And methadone metabolism can be sped up by rifampin, phenytoin, dilantin, alcohol, barbiturates, and carbamazepine. It can also be inhibited by things like tagamet, cimetidine, ketoconazole, and erythromycin. So it turns out medication interactions are quite important when it comes to methadone. There's cardiac considerations with methadone maintenance. In 1973, there were sudden deaths reported amongst heroin addicts, and they suspected there were prolonged QTC intervals. The prevalence is greater in people with methadone versus untreated heroin addicts, but there's really mixed evidence for prevalence. In short, I don't think the cardiac consideration should be a reason not to start somebody on methadone unless they have known serious cardiac arrhythmias. Buprenorphine. Buprenorphine was initially approved by the Food and Drug Administration in 2003, but there's been decades of experience with the medication in Europe. There have been very few fatalities as a result of buprenorphine, except with co-injection with high-potency benzodiazepines. And currently in places like France, where physicians don't need to be in an OTP or have an X license to prescribe, it represents a majority of French opioid treatment, the remainder of which is typically methadone. Buprenorphine is a semi-synthetic. It's 25 to 50% more potent than morphine. It has some kappa antagonist effects to the kappa receptor, which leads to less euphoria associated with the drug. It's also a partial agonist, meaning that it has a ceiling on analgesic effects, but much more importantly, it has a ceiling on respiratory suppression. And if you give it to somebody who is already on opioids, it can produce withdrawal. So a little bit about pharmacology. The endogenous opioid receptor is a G-coupled protein receptor, and there are different opioid classes and different opioid receptor subtypes. There's mu, delta, and kappa. The mu receptor controls analgesia, pain relief, both supraspinal, meaning in the brain, as well as in the spine itself. It produces euphoria, meiosis, the pinned pupils, sedation, constipation, respiratory depression, as well as addiction, and also causes hormonal changes. People on high-dose opioids, for men, they may notice a decreased testosterone. For women, you get irregular periods. The unfortunate thing that happens for many women is they don't think that they can get pregnant because they're not having their period, but they very much still can. The delta receptor affects supraspinal and spinal analgesia. And the kappa receptor, which is the subject of increasing research, also affects analgesia, diuresis, water retention, produces sedation, pupillary pinning, meiosis, dysphoria, psychomimetic effects, and respiratory depression and constipation. But remember, buprenorphine has kappa antagonism. And so with kappa antagonism, it likely affects somebody's tolerance to opioids. And in addition to that, kappa antagonism, interestingly, probably produces beneficial pain effects. Also with kappa antagonism, what we see is that people often receive a mood boost with buprenorphine. That's true of all opioids, but there's something significant about buprenorphine that I see clinically, in which people say that they feel much less depressed taking that compared to full agonist opioids. Now, there are opioid receptors all over the brain. In the limbic system, we see emotional regulation, euphoria. Central thalamus and substantia gelatinosa, we see pain regulation, analgesia. In the solitary nuclei, it produces a decreased cough reflex, and it affects the hypothalamus, decreasing sexual drive. Now, one of the key differences to remember was the difference between a partial versus a full agonist. Methadone is a full agonist. Heroin is a full agonist. Morphine is a full agonist, as are oxycodone and hydrocodone. Essentially, if you think about it as an on or off, methadone really turns the system on. Versus buprenorphine, think of it more as a dimmer switch. It's a partial agonist that basically turns on the lights halfway, but keeps it there over a longer period of time. And the idea behind methadone's action is that once it's on, if you add more opioids, nothing happens. Whereas with buprenorphine, you turn it on, but pull the switch off. And essentially, if there are other opioids introduced, they're just not going to have an effect. If we look at efficacy, this is a chart of percent efficacy, essentially percent of the opioid receptors that's turned on. And a full agonist such as methadone turns on 100% of the receptors 100% of the time. Buprenorphine turns the receptors on 40 to 50%, but it really holds it there. And if you look at an antagonist such as naloxone or naltrexone, that blocks the opioids. Anytime you're going up on the curves, you're feeling something, meaning that you're experiencing some type of effect. Whereas anytime you're going down on the curves, such as when blood levels decrease, you're noticing withdrawal symptoms. And the key here is that when you have somebody on methadone or another full agonist, if you start buprenorphine too early, you drop them down on the curve. They literally go down south. And that potentially can cause precipitated withdrawal. And that's part of the reason we use the induction protocols that we use, is to make sure that people are underneath the buprenorphine curve before they come back up, because we want to have people underneath and coming back up rather than on the top coming down. If we look at the effective buprenorphine dose on mu-opioid receptor bioavailability, this is sublingual buprenorphine, and at 0 buprenorphine, the parts in green, red, and yellow mean that there are a lot of opioid receptors available. At 2 milligram, we see a significant covering of those opioid receptors. When they get to 16, there are almost none available, and when you get to 32, it's really hard to find available opioid receptor sites. Buprenorphine, the pharmacology, it's a partial agonist at the mu receptor, but it has high affinity for the mu receptor, meaning that it turns it on halfway, but it sticks there really, really tightly. It can displace full opioid agonists such as heroin or methadone, and that can cause precipitated opioid withdrawal. The kappa receptor antagonism is interesting in its mood effects, and there's also significant evidence that kappa receptor antagonism can reduce the use of stimulants such as cocaine or methamphetamine. Buprenorphine is poorly bioavailable if just swallowed. Essentially, it gets broken down by liver enzymes. But it's much more bioavailable from the sublingual mucosa, both under the tongue as well as the side of the cheek. And you typically see a peak for 2 to 3 hours after the sublingual dose. Its profile effects is similar to that of other mu-opioids, but much less risk of respiratory depression. It's very hard to overdose on buprenorphine itself. There's a lower risk of physical dependence, and the withdrawal from buprenorphine is much less problematic. Buprenorphine can be abused, but usually as a second drug of availability. And there's lots of data that says that people who divert buprenorphine, essentially either give it or sell it to somebody else, the person who's taking it that has not been prescribed to them, they take it for its intended purposes, either detoxification or maintenance away from opioids. Another thing I should say is that people who have had experience with diverted buprenorphine are much more likely to enter buprenorphine treatment and also retain within treatment itself. We agree that diversion is not a good thing, but if you receive a patient who, say, is testing positive for buprenorphine, it's not a reason not to start them on buprenorphine. They could benefit from the treatment, and typically they want the treatment because it's just too much work to get it off of the streets. There's different buprenorphine preparations available for patient treatment. There's the generic pills, which are sublingual. There are ones buprenorphine only, and there's a combination buprenorphine naloxone pill. There's a Suboxone brand, which you can take sublingually underneath the tongue or slap it to the side of your cheek for buccal absorption. These are buprenorphine naloxone strips. There's a brand called Zubsolv, which requires lower doses because they acidify the pills. I think they use citric acid or something like that, which allows the buprenorphine to be absorbed more quickly. And then there's a medication called Bunavail, which requires lower dosing yet because it produces buccal absorption inside of the cheek. Now, when we instruct patients on how to take buprenorphine, we generally recommend to moisten their mouths with a drink of water and place the tablets under the tongue or the strips under the tongue or on the cheek. Lean their head forward slightly and let the tablets dissolve completely. Typically, the tablets take 5 to 10 minutes to dissolve and the strips about half of that time. Once they're dissolved, then the medication is absorbed. They can swallow their saliva or they can spit it out, but either way, they've gotten most of the medication in. We should instruct patients not to talk, otherwise they may leak out their medication, and don't chew or swallow the tablets because, again, that's just sort of wasting the medication. An ideal candidate for treatment with buprenorphine are individuals diagnosed with opioid use disorder. That is a principal reason to start somebody on buprenorphine. You want to look for patients who are not currently on methadone, but there's plenty of evidence that shows that we can do an easy transition from methadone doses of anywhere of 30 to 60 milligrams a day to buprenorphine. They have to have a willingness to comply with treatment, including counseling, drug screens, and the rest of it. Because treatment is not simply giving medications. It's about forming a therapeutic alliance, a bond with the patient, and also keeping them in treatment. There are no absolute contraindications for treatment with buprenorphine short of a buprenorphine allergy, and I've not heard of buprenorphine allergies, clinically speaking. Some of the pros of buprenorphine compared with the partial agonist is that there's a ceiling effect. It's safer in overdose. There's less euphoria, and you can actually dose it daily to every third day. It's a very long-acting medication. It's got a 72-hour receptor half-life, meaning once it gets the receptor, it stays half of the medication dissociates by 72 hours. You can do non-clinic-based outpatient treatment, including telehealth, and there's a lower abuse potential given the antagonist effects, meaning that if they take it in the setting of a full agonist, it will become an antagonist and precipitate withdrawal. The withdrawal is generally mild from buprenorphine, and the naloxone combination, such as in Suboxone, Bunavail, and Zubsolv, as well as the generic version, prevents people from injecting the drugs. The disadvantage of buprenorphine? Yes, it can be abused, but again, typically it's abused for its intended purposes. It's a partial agonist and may not be suitable for high levels of dependence, meaning that if somebody has a very high level of dependence, they may not be quote-unquote held with buprenorphine. Having said that, it's my belief that people should certainly start with buprenorphine unless they clearly need methadone. People who need methadone are people who inject heroin, are homeless, struggle psychosocially, and need that advanced level of treatment structure. Buprenorphine is poorly orally observed, and the effects are not reversible with naloxone. So if somebody's overdosed on buprenorphine, naloxone is not going to work very well, whereas interestingly, naltrexone will work. This is an older slide. The patient limit is now 275, and the medication has been historically more expensive, although the price is decreasing over time. I can't tell you what the exact price is per milligram, but it's no longer $1 per milligram. And most commercial insurances, as well as Medicaid and Medi-Cal, will provide some level of medication coverage. When we look at studies of buprenorphine, one of the questions that people ask, well, do we taper them or do we maintain them? And this is a study where 40 patients were randomized to buprenorphine maintenance, and the other 40% were randomized to buprenorphine detoxification. Now, we look at retention and treatment, and what we saw very clearly is people who were maintained on buprenorphine, they stuck in treatment. In fact, the majority of patients stuck all the way to 1 year. Whereas the patients who were in detox, it's like throwing a rock off a cliff. People drop out very quickly and left within 2 months of entering the study protocol. However, there's a tragic appendix here. What we see is that 4 of the 20 patients during the follow-up period died of an opioid overdose. This is an unacceptably high number versus none of the patients who were on buprenorphine died. So essentially what we see is detoxification is risky. It's risk of relapse as well as that of overdose death. If we compare buprenorphine and methadone, what we see is that methadone and buprenorphine have fairly comparable results as far as retaining people in treatment and reducing or eliminating illicit opioid use. Naltrexone, not so good. Drug-free, basically psychosocial-only treatment doesn't work very well. And any mode of short-term detoxification doesn't do well over the course of a year. So in summary, buprenorphine is a well-accepted maintenance therapy. The withdrawal is mild and it decreases opioid use. It's safer than full agonists such as methadone, and the diversion potential, such as giving it away or selling it, is much lower. And the final summary is opioid agonist maintenance, meaning buprenorphine or methadone, remains the gold standard for treating patients. Think of opioid use disorder, opioid dependence, opioid addiction as a kindled opioid deficiency syndrome. Patients, when abusing opioids and high doses of opioids, blossom their opioid receptors, and what ends up happening is that they need to remain on the medication, sometimes for years, maybe up to life. Now, clinically, I believe that everybody deserves a chance at detoxification. When they taper off of the medication, this should be during a time of biopsychosocial spiritual momentum. But detoxification rarely succeeds. The risks are high, including the risk of relapse and accidental overdose. Detoxifications should be driven by patients. They should be the ones asking for it. And the best medical advice that we give to them is that we'll be with you during the detoxification process, but we've got to watch out for the risks. And restarting opioid agonist medications such as buprenorphine or methadone is not a treatment failure. It is just another step of the process on the way as we help them to reach their goals. And finally, naltrexone has poor evidence base, even the long-acting injectable naltrexone. So to summarize, this is a maintenance medication. Methadone and buprenorphine are maintenance medications. The way I also like to talk about it with patients are comparing it to insulin and type 2 diabetes. It's a very apt comparison. Some people can manage their diabetes with diet and exercise. Some people need oral hypoglycemic medications, but some people need insulin. Yet we never talk to a diabetic and say to them, oh, when are you going to taper off of your insulin? Aren't you ready yet? And in some ways, the person who needs opiate agonist treatments for opioid addiction is that insulin-dependent type 2 diabetic. So it's a very similar comparison. Thank you for your time, and I appreciate your paying attention.